All right, let's tutor on the endocrine system. So we're going to talk about the pituitary, thyroid, parathyroid, and adrenal. And in the other, I will discuss diabetes. So in the pituitary gland, we can have acromegaly, which is that excessive growth hormone. Acromegaly is going to be in adults. Gigantism will be in kids. From pharm, you should remember that octreotide is going to be one of our meds that we're going to use. Another treatment option that we have is a hypophysectomy. This is where we surgically remove the pituitary gland. When we remove the pituitary gland, we need to make sure that we're teaching them ways to make sure their intracranial pressure doesn't increase. So we don't want to do things like brushing the teeth, blowing the nose, bending at the waist. We, as the nurses, need to monitor neurological status and vital signs. Remember, back from neuro, we're going to want to monitor any kind of nose drainage for glucose because it could be cerebrospinal fluid. We're going to want them to be semi-Fowlers to high Fowlers. We don't want them to cough. And we want them to note any kind of changes in their vision. And we also want to make sure that they don't develop any symptoms of diabetes insipidus. Okay, so let's talk about diabetes insipidus. So this is going to be where someone does not have enough of the antidiuretic hormone, ADH. So with this, someone's going to have polyuria, polydipsia, and then because of that, they're going to have signs of dehydration. So they're going to be tachycardic, hypotensive. They're not going to have good skin turgor. They're going to have those dry mucous membranes, weak pulses, decreased cognition, constipation, weakness, fatigue, things like that. Their urine is going to be very dilute. It's going to be clear, low specific gravity, low pH, low sodium, low potassium. It's pretty much going to be water. Our blood is going to be very concentrated because we're dehydrated. So we're going to have a high sodium level, a high potassium level. So that's the difference there. Our testing is going to be that water deprivation test. And our treatment's going to be our antidiuretic agents, kind of like our desmopressin and our vasopressins, which is going to help us hold on to our water. Kind of remember back to pharm what all of that stuff talked about. The opposite of diabetes insipidus is SIADH. Syndrome of inappropriate antidiuretic hormone. So this is the opposite. In this case, we are holding on to too much water. So we're going to get signs and symptoms of water intoxication. That's going to be that pounding headache, fatigue. We can get signs and symptoms of heart failure because we have so much fluid pressing on the heart. So with this being the opposite of diabetes insipidus, our blood is going to be very watered down because we're holding on to too much water in our body and not getting rid of enough through our urine. So our urine is going to be very concentrated with a high specific gravity, high sodium, things like that. Our treatment's going to be something that's going to want to make us pee, such as a loop diuretic and hypertonic fluids. So now we got thyroid disease. So we have hyperthyroidism. This can be caused by Graves' disease, thyroiditis, or exogenous hypothyroidism, which is when we have too much levothyroxine in our body. It causes the symptoms of over-medication. So with hyperthyroidism, our TSH is going to be low and our T3, T4 are going to be high. Our treatments include thionamides, which is like our PTU and our methimazole. Big things to remember are signs and symptoms of over-medication, such as symptoms of hypothyroidism and agranulocytosis. We also have our iodine solutions, which can cause that iodinalism, and radioactive iodine, which means we need to follow those radioactive precautions. Another route we can take is a thyroidectomy, whether it be a total thyroidectomy or a subtotal thyroidectomy. As far as during a thyroidectomy or post-op care from a thyroidectomy, we're going to want to do things like maintain that semi-Fowler's position and support the head and neck with pillows. We don't want them to extend their neck. We're going to do post-op vitals, just like normal post-op protocol. We want to check out their dressing. And we want to make sure, we want to monitor for signs and symptoms of bleeding. So this could be anything from vocal changes, coughing, clearing of the throat, a decrease in pulse, and a decrease in blood pressure, increase in pulse. We can have things, we need to make sure that we're monitoring for signs and symptoms of hypocalcemia, because remember, with that thyroid, we're also taking out the parathyroid, which helps our calcium. So we can have that hypocalcemia with the tetany and the nerve damage causing numbness and tingling. And then, of course, we need to talk about thyroid storm, which is that excessive thyroid as well. We need to know signs and symptoms of hyperthyroidism, which of course is TIGR, that nervousness, irritability, hyperactivity, that emotional lability, meaning we're kind of up and down. Weakness, muscle weakness, heat intolerance, so they're hot, weight loss, even though they have an increase in appetite, insomnia, diarrhea. They're going to be warm. They may have tremors. They may have visual changes. Their blood pressure is going to be high. Their heart rate is going to be high. And they can have a goiter. Okay. So now looking at the opposite, hypothyroidism. So with this one, it being the opposite, we're going to have a high TSH and a low T3, T4. Remember back from pharmacology, our treatment's that levothyroxine. And our signs and symptoms are Eeyore. So they're going to be fatigued, irritable, cold, constipated. They're going to have a weight gain. They're going to be pallor, depression, bradycardia, hypotension, dysrhythmias. Okay. And the big life-threatening emergency we have to deal with this disorder is that myxedema coma, which is going to come with respiratory failure, hypotension, hypothermia, bradycardia, coma, and could lead to death. And this is from continued hypothyroidism. All right, so last but not least, we have the adrenal issues, which is going to mostly consist of our Cushing's versus Addison's. Cushing's is too much of our adrenal hormones, including corticosteroid or cortisol. This is why when we have that a side effect of our long-term glucocorticoid uses is Cushing's, that moon face, swelling, things like that. So of course we're going to find weakness, fatigue, sleep issues. We may have irritability and depression. We're going to have the decreased immune system and decreased inflammatory response. They may have hypertension, tachycardia, weight gain, thin, fragile skin, dependent edema, meaning the edema is in their limbs. And then changes in the distribution of fat. So we're going to have that moon face, truncal obesity, and then that buffalo hump, where that fat's on the back of the neck. We have a high risk of fractures and osteoporosis, along with bone pain, and a high risk for falls. We'll also see muscle wasting, as well as hyperglycemia with that. We may look at elevated cortisol levels in the blood or in the urine when we do a cortisol level, because we want to see what their body's producing throughout the day. We're going to take those samples throughout the day, multiple times a day. And then with the opposite, we have Addison's disease, which is an insufficiency of adrenocorticosteroid hormone. So we're going to see things like that weight loss, a craving for salt, hyperpigmentation of the skin. We'll have nausea, anorexia, vomiting. We're going to have low sodium, high potassium, low blood sugar, high calcium. They may be dizzy with that orthostatic hypotension. And for this, we're going to replace the corticosteroids, so we're going to give them a steroid like prednisone, cortisone, or hydrocortisone. And of course, with this, we talked about the low blood sugar, the potassium, so we need to make sure that we're monitoring those levels. So if you remember one, you know the other because they're opposites of each other.